Katie Tseng is a PhD student in immunology and infection diseases at Washington State University, and she received her master's in public health from New York University in the United States. Her doctoral research applies computational epidemiology to the study of zoonotic risk at the human-wildlife environment interface. Prior to her doctoral program, Singh was a senior research analyst at the Center for Disease Dynamics, Economics and Policy, where she contributed to research related to the spread of COVID-19, antimicrobial resistance, and hospital-acquired infections.
Today I'm here to talk to you as a part of the Water for Public Health webinar on the topic of costing water, sanitation, and hygiene interventions in healthcare facilities across India. And this talk is based on the work that I conducted in collaboration with my colleagues at CDDEP. I wanted to start out this presentation about the importance of water, sanitation, and hygiene in healthcare facilities by briefly placing the topic in the context of the global COVID-19 pandemic and citing this statement from the WHO and UNICEF, which states that around 1.8 billion people are at heightened risk of COVID-19 and other diseases because they use or work in healthcare facilities without basic water services. So water supply, sanitation, and hygiene in healthcare facilities is really fundamental to stopping COVID-19 and is vital to the safety of healthcare workers and also patients. So in 2015, the WHO and UNICEF came out with a joint report on the status of WASH in healthcare facilities in low and middle income countries. It was the first global assessment of its kind and was drawn on data representing 54 low and middle income countries, concluding that 38% of facilities lack access even to rudimentary levels of WASH, or water, sanitation, and hygiene. The key findings from this report help frame this study in particular. And so the first question we asked is, why do we care? First off, WASH services are at the core of providing safe, people-centered healthcare. When we improve WASH services, we improve the quality of care, we reduce healthcare-associated infections, and in turn slow the spread of other problems like antimicrobial resistance. We also increase patient uptake of health services and preserve patient dignity, and we also improve staff retention and morale. As mentioned before, in low-resource settings, WASH services are absent in many healthcare facilities, compromising the ability to provide basic routine care and to practice infection prevention and control, or IPC. In essence, the absence of WASH is a limiting factor for healthcare provision as a whole. And again, this has really become apparent in light of the COVID-19 pandemic. You can also imagine that improving water, sanitation, and hygiene services and related behaviors like hand washing in healthcare facilities can also encourage patients and the community as a whole to improve their wash practices at home. And so there's a positive ripple effect that comes from improved wash provision in healthcare facilities. So in light of this, we had to ask, what are the challenges to improving wash services in low and middle income countries? I just wanted to highlight a few here that played a key role in this study that were cited in the WHO-UNICEF report, and that include the quality issue being one of them. So having access to, for instance, an unprotected tube well that's 500 meters away from a facility is very different from having a pipe water distribution system in the facility that is both safe to drink and available 24 hours. And so keeping this in mind, this variability, and also the WHO minimum standards for basic wash provision was really important to the study. Also, inequality in wash provision in healthcare facility poses a major challenge, as there's large disparities not only between countries but also within countries. And those disparities are not just at the geographic level, say when we compare urban to rural areas, but also at the level of care being provided. Finally, national action plans for improving and sustaining wash services in healthcare facilities was also found to be lacking across the majority of surveyed low and middle income countries, even though they play an important role in setting realistic goals and also creating national standards based on country context. And then finally, one of the key findings of the WHO-UNICEF report is that there's very little data available on WASH in healthcare facilities, especially for sanitation and hygiene. And of the 54 countries that had available data to contribute to this report, the most represented were in Africa, while the least represented were in Asia. So immediate incremental investments in WASH can also have big returns. First of all, it reduces healthcare costs by reducing healthcare-associated infections, which by no means is a small cost. For instance, in our study, surveyed healthcare facilities reported postpartum sepsis in mothers to cost roughly 30,000 rupees per case. And postpartum sepsis is often associated with poor wash conditions. And then in the case of neonatal sepsis, these costs can go upwards of 40,000 in some cases. Not to mention if you're dealing with a multi-drug resistant infection, those costs can often be many-folds greater as well. So investments in WASH can also save healthcare worker time when they don't have to, for instance, search for a hand washing station or for a women's bathroom. As mentioned before, it also increases uptake of services such as institutional births. And importantly, in a report just released by the WHO UNICEF a few months ago, they cite that for every rupee invested, you get a 50% return on investment. Jumping ahead to 2019, the WHO-UNICEF Joint Monitoring Program, also known as JMP, for water supply, sanitation, and hygiene, which is responsible for monitoring the 2030 Sustainable Development Goals that address universal access to WASH. They came out with the first sort of joint monitoring program report on water, sanitation, and hygiene in healthcare facilities. And in this report, they introduced new and existing water, sanitation, and hygiene service ladders, and they established national, regional, and global baseline estimates. The JMP Global Database is publicly available and includes national data from 125 countries, including India. And I point out this report because notably, national estimates for India based on their global indicators are very sparse, with data only available for certain facility types and limited service levels, and no data at all on specifically environmental surface cleaning. And this brings us to the current state of WASH in healthcare facilities in India, which based on recent estimates suggests that only 55% of healthcare facilities have access to improved sanitation, compared to the global average of 79% across low- and middle-income countries. Approximately 1 in 4 healthcare facilities lack basic water service, but it's important to note, though, that these estimates are based on a National Government of India survey back in 2009 with subnational coverage. So these sort of estimates do need to be updated. It's important to highlight here that it's both a quality and inequality issue. So even in facilities where WASH is available, the accessibility, quality, and functionality of these services can be inadequate or inappropriate. There also exists huge discrepancies in WASH throughout the country, with poor WASH provision in rural as opposed to urban areas, generally speaking. The healthcare landscape in India has also changed tremendously in recent decades, with increased utilization of private healthcare facilities across all wealth quintiles. And what this just highlights is not just a growing private sector, but a bottleneck in accessing quality public healthcare services due to having public facilities that are often overburdened, understaffed, and lacking in basic water infrastructure and resources. So investing in WASH provision in the public sector needs to remain a government priority in order to ensure access and availability of quality public healthcare services for all populations, especially those most vulnerable. For context, at present, the only national initiative for WASH in healthcare facilities is the Kaya Kalp program launched in 2015, which was an extension of Swachh Bharat Abhiyan, the national campaign for universal sanitation coverage. Most recently, the WHO released a report on the global progress of WASH in healthcare facilities, which highlights the progress made in participating countries since October 2020, as well as the gaps in knowledge. For India, that includes a lack of baseline assessment or data, including cost data, especially for estimating facility-wide implementation of water, sanitation, and hygiene interventions. So that brings me to our study, which is entitled Estimating the Cost of Interventions to Improve Water, Sanitation, and Hygiene in Healthcare Facilities Across India. I'd like to take this time to acknowledge my co-authors, Dr. Jyoti Joshi, the head of South Asia at CDDEP, Dr. Ellie Klein, a senior fellow at CDDEP's Washington, D.C. office, and Susmita Srivastava, who is an independent contractor. Funding for the study came from the U.S. Center for Disease Control and Prevention's Shepherd grant, and Shepherd stands for Developing Healthcare Safety Research. and this was given in September of 2017. We conducted a year-long project for the study to evaluate the cost-effectiveness of water sanitation and hygiene interventions, specifically to reduce healthcare-associated infections among mothers and neonates for the Indian public healthcare system. So this costing study was sort of one component of that project, with the other components being the development of a computational model used to determine how effective water sanitation and hygiene interventions are in reducing the burden of healthcare-associated infections. So jumping into our study now, the aim of our study was to estimate the national financial costs and 2018 prices of implementing basic water sanitation and hygiene interventions across the Indian public healthcare system, with the purpose of informing the allocation strategies of central and state governments responsible for the organization and delivery of healthcare services. As mentioned before, the scope of our study is to estimate the cost of the Indian public healthcare system, which for the purpose of this study was separated into 3 levels: PHCs, or primary healthcare centers, CHCs, or community health centers, and DHs, or district hospitals and medical college hospitals. Direct costs were estimated over 1 year from the provider perspective, or in other words, the healthcare facility perspective. We emphasize interventions generally recognized as primary mediators in healthcare-associated infection incidents due to inadequate water sanitation and hygiene. For example, interventions on water included upgrading facilities with below basic service to basic, and then farther upgrading those with basic service to advanced service levels. And so you might ask, what does basic mean? So we tried to map service level interventions on water and sanitation to the definitions used in the Joint Monitoring Program service ladders for water, sanitation, hygiene, and healthcare facilities. For instance, basic water service is an improved water source, like piped water or borehole, or water from a borehole that is on the facility's premise. However, at the time we conducted the study, there was no Joint Monitoring Program service ladder defined for hygiene in healthcare facilities, and so we constructed our own definitions for improved access to and availability of various hygiene interventions, and where possible we tried to apply WHO guidelines. For example, we define interventions on hand hygiene as improved access to and availability of hand washing stations to meet the WHO standards of 1 sink for every 10 inpatient beds. Moving forward, our data collection efforts were led by my colleagues Jyoti and Susmita, who were able to recruit the participation of 32 healthcare facilities, of which 19 were public and 13 were private, and these facilities were dispersed throughout 11 cities within 6 states, as you can see on the map. Using a survey questionnaire, Susmita was able to interview hospital administrators, department officials, and facility staff in order to obtain cost data sourced from expenditure reports and stock registers. So in terms of our methods, we took an ingredients-based approach in which we estimated the direct unit costs and 95% confidence intervals of each wash improvement based on the average price of each service unit and the quantity expected at each facility type. So for example, to improve sanitation from below basic service level to basic, we determined our service unit would be a flush toilet, and we considered the various cost inputs and resources that would go into providing a functioning flush toilet, such as the toilet itself, installation, plumbing connection, and labor. And then we calculated its average unit price based on capital and recurrent costs obtained from the surveyed facilities. Then to calculate the number of toilets required at each facility level to provide basic sanitation service that meet the WHO standard of 4 toilets per 20 inpatients, we estimated the number of inpatient beds as a proxy for patients, the number of staff, and the number of outpatient departments in each facility type requiring designated toilets for women and staff. The data availability was different across the board for each intervention and facility type, and so where data were not available for a specific facility level, we scaled the cost of interventions using estimates of facility size and or capacity, including the number of departments or wards and the number of beds, so on and so forth. Next, we estimated the national cost for each facility type and or setting by multiplying the average cost of intervention at the facility level by the proportion of facilities requiring that intervention, and then multiplying that by the number of facilities in India. To obtain estimates on the proportion of facilities requiring various service level interventions in India, it required an extensive review of the literature. And what we found is that there still remains quite a large knowledge gap on this subject that needs to be addressed still. And the number of facilities finally in India that was used to for these calculations were obtained from the Open Government Data Platform for India. So to give you an example of one of our sort of wash intervention calculations, here we have improving hand hygiene from unimproved to basic service level in an urban district hospital. And so as our unit, we have a hand washing station. And then we calculated capital cost per unit that was averaged across the surveyed facilities, the average recurrent cost per unit, and then we also estimated the number of units based on the WHO standard of 1 sink for every 10 inpatient beds. And also we added in an additional sink for every 4 toilets and 1 sink per outpatient department. And of course, this assumes that sinks are functional, accessible, and usable, meaning that they have uninterrupted running water, proper draining, and access to hand soap at all times. Next, we estimated the proportion of facilities that require intervention, and we did this by conducting a literature review, which allowed us to estimate sort of the percentage of facilities in India for each facility type that require upgrading hand washing stations from unimproved to basic and from limited to basic service level. And then based on the calculations that I mentioned before for calculating the sort of national costs, we estimate that it would cost roughly 56 crores to improve district hospitals across India from unimproved to basic service level for hand hygiene specifically. So moving on to our results now. Based on our cost analysis, we estimated the national cost of implementing basic wash services for 1 year across the Indian public healthcare system to be roughly 4,397 crores, or $632 million. In sensitivity analysis, we varied the proportion of facilities requiring wash intervention, which again was based on that literature review that we conducted. And we used the high and low uncertainty ranges to estimate the national costs. And we found that it would be, assuming the lower level estimates, national costs would be roughly 2,678 crores, or $392 million. And based on sort of the upper level estimates, the national cost would be 6,554 crores, or $958 million. And so I know that this range is quite large, but what it does tell us is that sort of we really need more data on the current status of water, sanitation, and hygiene in healthcare facilities for India in order to improve these estimates and provide better cost predictions. But importantly, in both scenarios of the sensitivity analysis, the majority of costs were still attributed to rural facilities and specifically to primary healthcare centers, with interventions on water remaining the costliest intervention, while interventions on hand hygiene and medical device reprocessing were sort of the least costly. And this brings us to our next figure. So this figure essentially shows us the distribution of national costs based on if those costs were attributed to capital expenditures, which are shown in the sort of green teal color, or if they were attributed to consumables, which are shown in orange, and how the proportioning of capital and recurrent costs differ between different intervention types. So for instance, if we look at panel A, hand hygiene requires substantial capital costs relative to recurrent costs, whereas medical device reprocessing requires far more recurrent costs relative to capital costs. If we look at panels B, C, and D, which represent the national costs of implementing wash interventions for each different facility type, we can also compare the cost of interventions among them. So in primary health centers, for instance, surface cleaning is the least costly intervention, whereas interventions on water are the most costly. In district hospitals, or DHs, however, medical device reprocessing is predicted to be the least costly intervention, whereas surface cleaning is the costliest. So what our results tell us is that at the facility level, district hospitals and medical college hospitals would require larger cost investments in water, sanitation, and hygiene. But at the national level, the majority of investments would actually be needed to improve primary health care centers, owing to the greater number of facilities lacking adequate services. Also, improving water services to advanced service levels would be the most costly intervention, but a necessary one for implementing infection prevention and control interventions that require water. For instance, hand hygiene and medical device reprocessing, which notably were also the cheapest interventions to implement. Finally, investment in WASH is particularly needed at the primary care level. And this is important because substandard water, sanitation, and hygiene in primary healthcare centers has impacts across the entire healthcare system, because healthcare-associated infections can spread rapidly as patients move between facility types, communities, and between also the private and public sector. And that can harm public perception of the value of preventative care as well. So there are some limitations and challenges that are important to highlight. First of all, individual costs obtained in the study were not generalizable to the whole of India. And in order to get generalizable data, that would require a national effort to survey a representative sample of facilities across the entire country, which the study just did not have the capacity to do. However, we do think that findings from the study do serve as a sort of a good start for a follow-up, more representative study, especially considering the policy momentum for SBM, now in phase 2, and also the Kalyakop initiative. Also, our study only estimated financial costs, which, unlike economic costs, do not include the opportunity costs of government-subsidized services. We also evaluated costs over 1 year only, which is useful for understanding where the greatest initial investments are needed, but it's not really realistic for actual financial planning or comparing life cycle costs of assets that have different useful lives. And we'll talk more about future research shortly. But first, I wanted to talk about sort of the way forward and what policy implications and strategies we can gain from findings of our study. And so the first thing is that engaging Panchayat Raj institutions is really critical to directing more funding towards water, sanitation, and hygiene in primary healthcare centers, as they can help generate funds at the village level to support upkeep of WASH facilities in primary healthcare. Next, village health, sanitation, and nutrition committees can serve as a key resource in challenging social behavioral norms and optimizing WASH uptake in healthcare facilities through community action and participation. It's also important to note that improving WASH in healthcare facilities is very possible. So for instance, the estimated first-year cost to implement WASH improvements based on our estimates were roughly around $354 million in capital costs and $289 million in recurrent costs. And that's comparable to other national health schemes like PMJ, which for the year of 2019 to 2020 was budgeted $936 million US dollars, or roughly 64 billion rupees or 6,400 crores. And also important is sustainability. And for sustainability to be achieved, it will require a coordinated central state effort, because while the construction of WASH facilities and healthcare facilities is supported by the Ministry of Health's sort of national health mission and is fully funded by the central government, ongoing maintenance of health services, including water, sanitation, and hygiene, is the responsibility of the state government. At the facility level too, establishing and maintaining WASH provision requires inter-facility cooperation and support from top management, especially in large multi-department facilities. So in looking ahead, there are a lot of potential areas where future research is needed. For example, building on this study, a more comprehensive survey with weighted sampling to obtain statewide, rural, and urban estimates for the cost of improving WASH could be beneficial to producing improved national cost estimates. And they can be used to inform policymakers of the correct costs and return on investment for the different facility levels, and to prioritize and make a phase-wise improvement plan with adequate initial and running costs. Future research is also needed to evaluate the added value of investment in water, sanitation, and hygiene for things like COVID-19 and other pathogens. And related to that is also the need to assess the value of improvements in water sanitation, hygiene, and infection prevention and control on not only the quality of healthcare services, but also on specific issues like antimicrobial resistance, which is an area that CDEP is currently working to address. One approach is to conduct, for instance, a cost-effectiveness study or a cost-benefit study to making the case for improving WASH in healthcare facilities, not just for health promotion and patient safety, but also specifically to prevent diseases like COVID-19, as mentioned before, as well as antimicrobial resistance. And then lastly, we need models for public and private partnership, as well as citizen participation for improving WASH in low and middle income countries at the district and state level, because in doing so we can understand the other positive spin-offs that can be gained from improving WASH in terms of improved patient satisfaction with healthcare services, workforce satisfaction, and disease control, like decreasing rates of infections. And then there's also economic benefits for healthcare facilities, the health care system as a whole, and also governance at the district, state, and national levels, including improvements in accountability in clinic managers and clinic managers and officers. So as I just mentioned, understanding the cost of interventions in relation to other competing needs is a necessary step in developing cost effectiveness or cost benefit analyses, which is sort of what we're working on right now at CDEP. For this cost-effectiveness project, our objective is to evaluate the cost-effectiveness of WASH interventions on reducing bacterial health care-associated infections in mothers and neonates in the Indian public healthcare system. And then, in doing so, to also identify gaps in understanding of the transmission dynamics that are involved and the relative impact of the WASH interventions on pathogen transmission. And so I'll just spend the last 5 minutes here talking briefly about about this current project. So in brief, the methods that we use include developing a compartmental model that's composed of individuals who are either susceptible, colonized, or infected. The rates in which they enter or leave different compartments and the rate in which they contact their environment are determined by a system of ordinary differential equations. For instance, the force of infection is dependent on the transmission rate, the rate patients come into contact with different environmental compartments, and their probability of acquiring bacteria from those various compartments. We model two different wards, a delivery ward and a neonatal ward, and we assume that colonization or infection of patients occur principally through contact with healthcare workers or different environmental reservoirs, like medical equipment or the environmental surfaces that surround them. We then fit our model to estimates of hospital-acquired infection-related mortality and deaths among mothers and newborns, and then our model parameters are estimated from literature. So for this cost-effectiveness study, we model 5 intervention scenarios, all of which were dependent on improvements in WASH service, and many of which combine multiple interventions into one. For example, in scenario 3, we implement improved access and availability to all WASH components, including increasing access to and availability of toilets, sinks for hand washing, and equipment and staff for environmental surface cleaning, linen reprocessing, and medical device reprocessing. And of course, all of these interventions require improving water to advanced service levels, where water is being piped into the facility with various distribution points throughout. And looking at these water-intensive interventions, we thought it was also important to look at water-independent alternatives, which were modeled in scenario 4, and include interventions on hand hygiene using alcohol-based hand rub, outsourcing laundry services, and using disposable medical equipment where possible as an alternative to sterilizing equipment, which requires water. And then in terms of our calculations for cost effectiveness of these sort of various scenarios, we used what's called the incremental cost effectiveness ratio, or ICER, which is essentially the difference in cost between two scenarios divided by the difference in their effect, as shown in the equation here. And in our case, when we talk about the cost of a scenario, we're actually talking about the net cost. So the cost of the intervention in that scenario minus the cost averted from preventing a certain number of healthcare-associated infections. For effectiveness, we measured this in terms of maternal and neonatal disability-adjusted life years, otherwise known as DALYs averted. And then we evaluated the cost effectiveness of these intervention scenarios over a 5-year period, accounting for inflation where possible and a discount rate of 3%. As mentioned before, this project is still underway, and so our results are to be determined. And that pretty much concludes sort of my talk. Here are some references that were cited in this talk, and then other resources that you may or may not be interested in and that you can look into if you'd like. Okay, and if you do have any questions, please feel free to send queries to either me or Dr. Jyoti Joshi. Our emails are provided here. And lastly, I do want to note that the costing method for each intervention type and facility level cost estimates and adjustments that were made are available in the methods section of the paper. And the paper is available on the BMJ Global Health website, I believe without a paywall. Or you can reach out to me and I can provide you the text as well. And then more detailed information regarding the types of facilities surveyed, the cost inputs for estimation, the proportion of healthcare facilities requiring improvement in WASH, and the survey questionnaire itself can also be found in the supplementary materials in the paper. And with that, I just wanted to thank the National Institute of Hydrology for allowing me to participate in this very important webinar. And thank you for listening.